a frailty dimension into LOCUS for seniors in a medical psychiatry population. So welcome everybody today, and we will have a Q&A session at the end of the presentation. So our Manager of Research, Perry Kim, will facilitate the Q&A. So please submit your questions online during the presentation, and we will try to answer as many as possible. We will also be open to submitting your questions if they're unanswered to the presenter today to maybe have your individual questions answered. A survey will pop up at the end of the presentation, and this is to give us better feedback on how we can improve our webinar series. And the webinar slides and the video will be up somewhere between the next 24 to 48 hours, and you'll see the URL there on our website. We have a few webinars booked from now, I guess, till the end of March. Please go up to our website and look at the webinars that are already booked, and we'll be continuing to add them. We like to at least have 2 webinars per month. And so on Wednesday, September the 27th, we have the Improving Palliative Care in Long-Term Care Homes using Participatory Action Research. On Wednesday, October 11th, we have the Teleprom, a study of evaluating access and care delivery of telehealth services among community-based seniors. And then on Wednesday, October 25th, you'll see a trend here. It's usually Wednesdays. We're having the nutritional pathway and optimized protein supplementation for malnutrition patients living with frailty. So as we go through some of the CFN events that are coming up, we do have the KT competition in process. It is already, all the applications have been received, and it is going to scientific review as well as our research management, and we will be making the final announcement in late November. We have currently a 2017 Catalyst Grant competition that is still open. The intent to apply is due on Friday, October 6th at 5 p.m. And again, we have information on our website on the specific details. We do have New Brunswick Health Research Foundation as a partner and the Canadian Institute of Health Research. So today I would like to give you some information on our presenter. He's an assistant professor. I should say his name is Richard Schulman, and he's an assistant professor at the University of Toronto, Faculty of Medicine in the Department of Psychiatry, a division of geriatric psychiatry, service medical director for the Seniors Mental Health Services at Trillium Health Partners, and he also is a consultant geriatric psychiatrist to the Special Behavioral Support Unit at Sheraton Villa Long-Term Care Facility. So Richard, I'll hand this over to you, and you can start your presentation today.
Okay, thank you very much, and welcome to everyone listening in cyberspace. I'm broadcasting from the Seniors Mental Health Inpatient Unit at the Mississauga Hospital, which is one of the 3 hospitals of Trillium Health Partners. The other 2 are Credit Valley Hospital and the Queensway Health Center. And we're going to talk to you about our study, and I'd like to say thank you to the Canadian Frailty Network for funding our study, and our partners here at the University of Toronto, the Mississauga Academy of Medicine, and CAMH. So let me just show you who was in our project. We have a research assistant, a statistician, a geriatrician, Jason Kerr, and our principal investigators are professors of psychiatry, Dr. Mulson, Dr. Geist, and also the nurses, occupational therapists, and social workers on our seniors mental health outpatient and outreach team were also involved, and I'd like to thank their participation. So first, before I explain our study, I'll have to explain some of the basic concepts because the audience may not be too familiar with some of these issues, as they may be more centric to the mental health world, and for the mental health audience, there may be some issues that they're not so familiar with that are related more to the geriatric medicine world. So I'll try and explain the concepts and the reasons why this study was of interest. So first of all, we have the idea of utilization management, which is the aim to manage healthcare costs by influencing the level of care decision, the level of service delivery, not the actual care. It's not what medication you use or what procedure you use or what test. We're not talking about pathways of care. We're talking about service delivery, whether someone should be in a hospital or not, whether you should have an outreach team or not. Because this comes from the United States, where they have managed care, which is an insurance company is paying for care, and the insurer is worried about the costs. Is the treatment and the care justified for the costs? Maybe we can manage this person without requiring hospitalization. Hospitalization is very expensive. So this idea was born out of that issue, to develop methods to examine if the service delivery is justified, if the costs are justified by the patient care needs and the treatments that can be offered. So that is where the idea is coming from. So the American Association of Community Psychiatrists developed an instrument designed to maintain this balance between the quality of care and cost containment, the wise use of resources. And that tool is called LOCUS, the Level of Care Utilization System. And it's a tool to validate the level of service care delivery offered to a patient. So the LOCUS tool was designed for the assessment of adults, not seniors, with any type of mental health problem from any type of socioeconomic background. And a child and adolescent version was developed, but this work has never been validated in seniors. There's no geriatric version. So before I show you what the LOCUS is examining, the idea here was that our hospitals, Trillium Health Partners and CAMH, were using the LOCUS in their mental health departments to validate the level of care being offered for adults. And the idea came that it should be used in seniors also, but the tool had never been validated in seniors. So we're going to be getting at the idea of how can we try to validate it in seniors. But before we do that, you need to know what is the LOCUS tool. So this slide will start explaining it. The tool looks at 6 levels or 6 parameters in the patient: the risk of harm, the functional status, their medical and psychiatric comorbidities, the environment that they'll be in where they can recover, their past history and history of recovery or not, and the patient's attitude and engagement with the healthcare team. So the recovery environment is actually divided into 2 scales. I'll show you next slide. So in total, we'll actually have 7 scales, and each one can be scored 1 to 5, and the tool will give you a total score. So let's just look at each parameter in a little bit more detail. What do we mean by risk of harm? So this refers to suicidal ideation or intention, or rarely violence to others, but mostly in regards to harm to self. Functional status looks at the person's ability to meet their IADL responsibilities and also their ADLs, which the geriatric audience we're all familiar with. Then we look at the medical and psychiatric illnesses, the course, the severity, and then the recovery is divided into 2 areas. Number 1, the stressors in that environment and the supports in that environment. They're both scored separately. And then you have the response to treatment in the past, and the attitude and engagement, the ability and desire for change. So these are all scored. And then the tool gives you a recommended level of healthcare service required. These are the 6 levels that the LOCUS can recommend. Level 1 is a basic recovery, maintenance, and health management. This is the minimum support. Level 2 is an outpatient support. Level 3 is a more intensive outpatient support. This would be with, for example, in the psychiatric world, case management. In the regular outpatient support, the patient may come to a doctor's office or to a clinic. But with a higher level, a clinician is assigned to that patient who helps manage their healthcare needs with navigational and therapeutic aspects to the case management. Then we can go a higher level to a non-residential, but even more structured case management. So the person could be living in their own home, but they might have daily visits, for example. Then we have the non-secured residential, which is a supportive setting. And then finally, the highest level of care is the inpatient hospital. So what was our hypothesis? Well, first of all, our hypothesis was that a geriatric customization of the LOCUS would require incorporation of a frailty dimension, because we know, and I'm going to review and show you, for those who are not so familiar, who are the seniors mental health patients that we see in our clinical populations. But we want to include a physical frailty dimension, and then we're going to look at the variance between the level of care recommended by LOCUS and the actual level of service care delivery being provided. And then we'll do a statistical analysis looking at many different independent frailty variables to try and determine what variables predict the variance between the recommended level of care and the actual level of care. So first we had to decide what are the frailty dimensions that we want to measure. So these are the 10 measures: the age, the gender, the clinical frailty scale, which we can discuss momentarily, whether they had a recent diagnosis of delirium, if they have a diagnosis of dementia, a diagnosis of depression, if there's any alcohol abuse. We looked at drugs, and these are the specific drugs we looked at, whether they're on a benzodiazepine, an antipsychotic, an anticholinergic, a narcotic, a non-steroidal and anti-inflammatory drug, an anticoagulant or insulin. And then lastly, is their medical disability sufficiently severe to impact the quality of life? And are they socially disconnected? That means few social supports, poor social health. So here's the clinical frailty scale. We don't use this much in the mental health field. It's used in geriatric medicine, and it's to help describe the level of frailty. So let me just comment a bit on frailty, since it's more of a medical rather than psychiatric term. Well, frailty is used to describe vulnerability to disability or death. It's not synonymous with disability, and it's not synonymous with comorbidity. It's a vulnerability to disability. And usually the more frail, the more cumulative decline in multiple organ systems in a person, typically 3 or more, and you become more frail. And this frailty makes you more vulnerable to a greater decline if you are confronted with another medical or psychiatric problem. So that's why we're interested in knowing how frailty impacts the level of care. And the clinical frailty scale gives you these levels of frailty that it's quite an easy scale to use. You have very basic explanations for each level, and you can score the patient by having a basic clinical interaction with them and easily apply the score. What about the other frailty measures? Where did they come from? So this came from my description of what are the factors that make up patients who have mental health problems and who are elderly. The schematic is made over a baseball field to make it easy to remember the different issues. So for people in the field, you're familiar with the 3 Ds: dementia, delirium, depression. And this has been written about, and the Ontario Nursing Association has educational material about this. And there's been literature describing the 4th D, which is drugs. But I'm suggesting that there are actually 10 Ds that can be applied to almost every patient we see in seniors' mental health. So we'll go through the positions on the baseball diamond, and it's easy to remember. So dementia, depression, delirium, that's the pitcher, home plate, first base. Then that third base is drugs. Then we add disabling medical illness, the disconnection socially. Then you have delusions, decision-making capacity, discharge planning, and that's not just discharge from a hospital. It could be related from your home to a retirement home to a long-term care home. It means moving from one place to another. And then in the bullpen, ultimately, is death or dealing with death is the last issue. So you can see that this is where I took the variables to study along with the clinical frailty scale to see what are the variables in our patients that may impact the level of care, contributing additional information to the locus. Okay, so who are the patients that we're studying? Who do we see in the senior mental health world? So there are 4 types of patients who have mental health problems who are elderly. First, we have those who are growing older with a recurring, persistent, or chronic mental illness. So this is, for example, schizophrenia. Starts off in late adolescence or early adulthood, or even the late onset that starts after age 40, and then persists into late life after age 65. You can have the same thing with depression. You have early onset, recurrent major depressive disorder with recurring episodes into late life. Then you have those who experience mental illness for the first time after age 65. For example, depression related to late life that starts because of small vessel vascular disease in the brain. We also have a very late onset type of schizophrenia. So these are first time onset. For example, you can have mania for the first time in life after age 65. And then we have patients with dementia and suffering from BPSD, the behavioral and psychological symptoms associated with dementia. And then finally, you have those with chronic medical problems that have known correlations with mental illness. So examples, Parkinson's disease, which has both high rates of depression, more so than would be expected from the physical limitations of the illness. We have Parkinson's disease dementia. We have stroke-related depression and dementia. We have anxiety related to COPD and other illnesses. So these are the 4 types of patients that you'll see in a senior mental health clinic. What about in the primary care clinic, the primary care world? What are the seniors like in those environments? Well, the thing to remember is that most patients will have multimorbidity, more than 2 chronic conditions, a condition that is persisting over a period of years to decades. And for those with mental health problems, it's known that the major physical chronic conditions that they suffer from are heart and stroke disease, diabetes, arthritis, COPD. These patients have more visits to their primary care doctor, longer hospitalizations, more frequent emergency room visits. And we also have those seniors with medically unexplained symptoms, whether they have an excessive preoccupation, that the underlying problem, it may have no definitive medical diagnosis, or there is a definitive medical diagnosis, but the functional disability is much more than what's typically anticipated. So these are also comorbid psychiatric and physical health type of patients that we see. So what about the service delivery? How do we meet the needs of all of these seniors with comorbidities? So this 4-quadrant schematic gives you an idea of how we can divide healthcare delivery. In the bottom left-hand corner is the primary care world, quadrant 1. Low mental health needs, low physical health needs. You have prevention, you have health teaching. That's and screening and initial diagnosis. That's in the primary care world. Then going along to the right, they have higher physical health needs. And this may need specialty care in geriatric medical clinics. And going up on the left is the higher mental health needs, who might need specialized psychiatric services. And then finally, in the top right quadrant, you have patients with both very high mental health needs and physical health needs. So how does the geriatric psychiatry world meet the needs of these seniors? Are we focused mostly to the top left? Do we come across to the top right as well? Is there enough of us? These are some of the questions. If there's inadequate service, if we don't have enough service to meet the needs, we have to push services down towards the primary care world, for example. So let's take just a quick look at the American recommendations, and they did a task force on the ability of their healthcare world to meet the needs of seniors with mental health problems. And their recommendations was that there's not enough specialists, and this is not just doctors, it's the entire workforce. There's too few and not prepared. So that's ominous and worrisome. So if that's the case, we have to understand what are the factors that will determine the appropriate healthcare delivery for which patients actually need the specialty care, which ones need to be in hospital, which ones can be managed mostly in the primary care world. What factors will determine that? That's why this area of research has importance. So we did a study. For almost a year, we collected data because our hospital had begun doing the LOCUS tool on every patient. So that means every outpatient, every inpatient was getting a LOCUS score. It's a computer-based program. It can be done quite quickly. And so this was already part of the actual care. So our study was really a quality improvement project. We did not need to get consent from the patients. This was part of their health care. We did get REB approval from both hospitals because we had to have our clinicians document some additional data, the frailty variables I mentioned, and enter that into a database. So that extra work was consented to by our clinicians who volunteered to help us, and that was REB approved. So at our THP site, we had multiple clinicians involved in the live data collection. At the CAMH site, we could not do it live, so it was done through retrospective chart review by our research assistant. Okay, so you can see there at CAMH, it was about 200 charts were reviewed by the research assistant, and then she completed the LOCUS. Or these patients already had a LOCUS, but she completed the clinical frailty scale and documented the frailty dimensions. based on chart review of those patients. And then we looked at what level of service care delivery was each patient receiving. Were they in the hospital? That's easy to document. If they are not in the hospital, were they just seeing an outpatient psychiatrist? Were they getting outreach? Did they live in a retirement home? What level of care was being provided? So this is how we did it. Because if you remember, on the right, you see the 6 LOCUS levels of care. So the LOCUS not being designed for seniors, we had to come up with a similar level of care system on a 6-point scale that would be equivalent. So for example, the recovery, maintenance, and health management, the minimum support level of care, we called that just need to see the primary care physician. An outpatient visit, we called that seeing an outpatient geriatric psychiatrist, but there was no outreach component. In the intensive outpatient, the patient is receiving outreach by a nurse or social worker or occupational therapist, in addition to the visits to see the doctor at the clinic. In the intensely managed non-residential, we called that a retirement home setting. The extra support of the supervised environment, the retirement home, because we don't have an ACT team that does intensive case management in our seniors program. So we consider the retirement home a higher level of supervision and support compared to being in your own home receiving outreach visits. Then the non-secure residential, we called that equivalently long-term care or assisted living in a retirement home, since we have 4 retirement homes in our catchment area that have locked memory care units that are basically equivalent to a nursing home. So that was our level 5, and level 6 is the inpatient hospitalization. So we collected the data, and this is just to show for those who have an interest in statistics, this is how our statistician evaluated the data. And then what we did was we did a reliability testing, because we had about 10 different clinicians doing the LOCUS on our live cases, and we had to make certain that there was reliability between the clinicians doing the LOCUS. And we look back at the original study to develop the LOCUS, and they'd done the same thing. So in their 2003 study, they didn't have live patients. They did it based on case vignettes. They had 10 case vignettes. Then they had different reviewers look at the vignettes and apply the LOCUS. And then they looked for the interclass correlation coefficient to describe the reliability between evaluators. And they got a score of 0.68, which they said was good reliability. So we did similar. We had 10 clinicians. We had 10 charts pulled from the study. These were patients who had actually pulled 12 charts, patients who completed the LOCUS. We chose 3 with low scores, 3 with medium low scores, 3 with high LOCUS scores. The clinicians reviewed the cases and applied the LOCUS. And we found our inter-rater reliability was actually better than the original study one. We had 0.716. So our inter-rater reliability was quite good. Okay, so here's our data. First, just to give you an idea of the frailty. This was the there is a distribution. Similarly, for level 5 care, the locus was the best determinant. We can see that, but the locus does not necessarily always predict the true level of care. Sometimes it's recommending a lower level of care. When it came to the 4th level, you can see it's pretty much equally distributed. The locus is recommending a lower level of care about half the time and a higher level of care about half the time. And same thing with the level 3 care. There's quite a equal distribution on either side of the recommended and actual level of care. Sometimes the locus is recommending a lower level, sometimes it's recommending a higher level. So that's what our data analysis was for, to examine what factors that we measured, all those frailty variables, which factors help determine this variance between the locus and the actual level of care provided. So these are the results. So the locus score can be improved if we look at certain variables, and these were the only variables that were statistically significant. First of all, the choice of hospital did make a statistically significant difference. That the psychiatric hospital tended to predict a higher level of care because there was a higher predictability for those patients to be hospitalized. So that might be related to data, since there was a higher percentage of CAMH patients were inpatients compared to THP patients. But let's look at the next factors. A recent diagnosis of delirium or use of an antipsychotic or benzodiazepine medication predicted a higher actual level of care. So this intuitively made sense to us. If you had a recent diagnosis of delirium, there's a higher likelihood that you'll need to be in hospital, or that if you've come out of hospital, you'll need a higher level of care because of the impact of delirium in seniors. Similarly, we tend to discourage use of antipsychotic medications to manage behavior in dementia patients unless absolutely needed. And you can see that for patients who need an antipsychotic medicine, and also for those who have mood disorders, if they need augmentation with an antipsychotic, or if they've had a history of depression with psychosis and need an antipsychotic, it's not surprising they need a higher level of care. Same thing for the benzodiazepines. We don't wish to use benzodiazepines. We tend to use them by necessity. And the patients with mental health problems who remain on benzodiazepines despite our attempts to wean people off, this is not unusual that this would predict that these patients require higher levels of service care delivery. So this seems to make sense. Then we found that an increase in the clinical frailty scale score or treatment for depression predicted a decrease in the actual level of care. So the more frail, the lower the service delivery required, the lower level of service delivery. And the same thing for depression. So this was more difficult to understand. Our frail and depressed older patients are receiving LOCUS scores indicating a need for services higher than what they were actually receiving. Why is that? Well, we're not sure. We would have to do further analysis to understand what are the factors that are causing higher frailty or depression to suggest that you could provide care with a lower level of service delivery. But it's interesting to think that, because currently we are looking at increasing our collaborative care models with the primary care world specifically for depression. In our Medical Psychiatry Alliance work, We are currently doing a project where we're trying to manage seniors with depression and medical comorbidity at the primary care level without requiring bringing them for a consultation at the specialty clinic. We are using nurse care managers for that project. But we have this concept that perhaps for depression with medical comorbidity, you can manage these patients in the primary care world, and our data is possibly suggesting that. So if you were to develop a customized Jerry locus, which is the ultimate goal, you would have to factor in trying to understand why patients with depression and more frailty, the locus seem to exaggerate the level of care required. So what are the limitations of our study? Well, it's the sampling is random, so we may not be able to generalize this to specific populations. So we didn't study specifically depressed patients or demented patients. It was whichever patients were coming to the clinic that day. And of course, the questions of the locus are not designed for seniors. They're designed for adults. And are the questions within the locus itself applicable to seniors? We don't really think so. That's why we want to look at these additional clinical frailty variables to see if we could customize the locus without having to make a new tool altogether. Just a customization, because the children's version, it's basically just a customization of the locus. So that's the ultimate goal, but for now we found some interesting preliminary data, and I'll open it up to questions from the audience.
Okay, thank you, Richard, for the very informative presentation, and thanks for sharing your work today. And we'll now start the Q&A with Perry. I'm asking everyone to please submit their questions or continue to submit their questions so that we can answer them before we end today's webinar. So go ahead, Perry.
Hi, Richard. It's Perry here. Thank you for your talk. Very informative. As we wait for questions to come in, maybe I'll start off by asking just a general question. This is certainly not my area, and LOCUS is something new to me. Just curious why, or whether other areas of medicine have similar tools in terms of service delivery management. It seems like LOCUS is something unique to the psychiatric field, and I'm curious as to why that is, as opposed to other areas of medicine.
Right. I mean, it's really an interesting problem, because before this work, we were not familiar with utilization management tools or strategies either, because it really came out of the managed care world of the United States. And it was really an issue more so for the mental health world, because it's mental health that was so inadequately funded in the United States, and mental health patients seem to be discriminated at in that they could not get hospitalization, or their hospitalizations would be cut short, because for hospitals and for the payers for healthcare delivery, it's well known that the psychiatric patients, they have the highest length of stay and the highest costs, especially, for example, schizophrenia in the adult world. It's one of the biggest costs for inpatient care in America, especially because of length of stay. So then you had these insurance companies demanding discharge as soon as possible. They used to have a nurse who would review the care of the patient and the patient's situation with the attending doctor, and they would make these decisions about whether they would agree to pay for ongoing inpatient care or not. So that's why I think this is really possibly somewhat unique for the psychiatric world, where we had these lengthy and expensive hospitalizations more so than in the medical world. And it's not as straightforward to agree if someone needs to be in hospital when they have a mental illness compared to a physical illness. Because a person's hallucinating, What does that mean? They have to be in hospital. If there's a suicide risk, who's the expert at determining if that risk is reasonable for them to be in the community, or do they have to be at home? So I think it's somewhat unique to the psychiatric world, and it was so foreign to us in the seniors mental health world that when it was imposed on us by the hospital administration, that's when we had the idea that, you know, we should study this and understand it rather than just doing it because it's imposed on us. So I'm not really familiar with similar utilization management tools for medical patients only, but when we looked at this for seniors specifically, we couldn't find any similar tool for seniors.
Oh, very interesting. Certainly a lot of different challenges. I'm curious, how well is LOCUS adopted across the Canadian healthcare system?
So I only can go by what I've heard. From my own experience and understanding is that the initial enthusiasm is not as high as initially. That I believe CAMH has dropped using the LOCUS, and Ontario Shores was using it, and I believe they've dropped using it, especially in their seniors population. I believe they dropped it from being used. And we don't have the same enthusiasm for it either on our inpatient seniors mental health service. So it's academically interesting, but there seems to be, in our Canadian healthcare system, especially in Ontario, there's so many other factors that impact the service delivery, social factors, housing factors, that we don't have much control over. What the benefit of LOCUS is to analyze a group of patients, so you can find some themes that can describe the variance between what the LOCUS predicts and what's the actual level. So you can go to the government or go to your local LHIN and you can argue, well, you know, these patients are remaining in hospital even though they shouldn't be. Their level of care could be in the community, but there's inadequate supportive services, there's inadequate housing, there's inadequate long-term care availability. That's maybe where it has some value.
Okay, very interesting. One of the questions we have in the queue is, how was the medically disabling dimension assessed?
So it was basically just if we want to have a medical condition that impacted function. So it would have to be not something like, for example, diabetes that's well managed. Not just because they have a diagnosis, that wouldn't be sufficient. It would have to be that it disables them functionally somehow, either in their IADLs or ADLs, so that we would count it.
Okay. Another question we have is, in terms of the clinical frailty scale, or just frailty assessment in general, I'm curious as to how you use that in your current practice, and generally amongst your colleagues, how is frailty utilized, if at all?
So in the seniors mental health clinic and inpatient, we do not use the clinical frailty scale, and that was one of the ideas in the study, because we want to look at more of a medical psychiatry view and more of a holistic view of the patient that looks at the medical and psychiatric factors. And we thought that perhaps that would be something new for us, is to have a tool that could give us a snapshot picture of the overall physical frailty. That's where the clinical frailty scale comes in. But in this mental health world, we don't use this tool very much at all. And so that was something new for us to learn it and start to use it. But it's not in the usual clinical practice to be using it in the mental health world.
Well, interesting. Thank you, Richard. I see that we're coming to the end of our presentation, and I think there's one more question that just came in. What was the functional assessment tool used to evaluate impact on function, or was the impact self-reported?
Purely self-report and the clinician's clinical impression, but we did not use an additional functional tool, no.
Okay. So on that note, I think there may be one or two questions. There's some comments coming in saying thank you for the presentation today. And I'm not sure, Richard, if there's an email that you could provide that if they wanted to have a follow-up email to you. If there is, we'll put that up on our website today. With the presentation and the video, which should go up either later today or later tomorrow. So thank you, Richard, for sharing your work today and answering these questions. And thanks to everyone joining us today. Just a quick reminder, as the survey will pop up on your screen, and please provide feedback both to CFN and to any comments to our presenter today, or follow-up questions that you may think of after the webinar is over. And we hope you can join us for our next network webinar on Wednesday, September 27th. And please go to our website to register. And that ends today's webinar. So I'm hoping everyone has a great rest of the day. And again, thanks to everyone for coming on. Goodbye.
Okay.